Robbie. So again, we're looking for a case to discuss today. So anybody has a case they brought to VMR today, please let us know. And then we'll be excited to discuss that.
Hello, everyone. Yeah, nice to see you all. Sorry, I'm a little clunky. I'm using a different device, and it's hard to get used to. But I'm excited to be here, and especially excited to see a lot of familiar faces in the chat. I see Malika's here. Rodrigue, I haven't seen you in a while. Welcome back. Amanda is here. Nikita is here. It's a whole party. Any of you guys have a case you want to nerd out about today? Chat again.
Oh, nice. Amanda as a case.
Oh, no way. All right, Amanda. Oh, so exciting every single time. All right, the floor is yours. You want to just do a quick introduction? Let us know who you are, and we will jump right in. I would love to let you know one thing, which is that we're going to try something new today, which is to not have a scribe and teaching points, just to have the case flow as a conversation between all of us. For two reasons. One, it's good practice for Leah and I to continue to discuss the problem representation, but also let our amazing team take a break occasionally. All right, Amanda, please jump in.
Hi, everyone. I am Amanda. So I think it's not new. I love presenting cases, and I'm here to present today. So I understand English, I speak English, but I have some problems with pronunciation, but I'm here to try, and I hope you enjoy the case.
Oh man, your English is better than most. It's much better than my Portuguese, and we love having you here. So please take it away. We're ready whenever you are.
So let's start. It's an 18 years old male comes to JD complain jaundice 1 month ago.
Sorry, I didn't hear. What was the complaint? The main?
Jaundice.
Jaundice. Okay. So an 18-year-old male with jaundice, that is very interesting. So it is just one symptom, but something that I think we have seen a lot already on VMR. And with jaundice, I tried to think about, is it prehepatic? Is it hepatic or post-hepatic? And then I think the main lab value that will help me distinguish between the different causes will be the bilirubin, and see if it's direct or indirect, or even both that might be elevated, which can also be the case with like intrahepatic or even mixed problems. And then of course, once we think it might be post-hepatic, the ultrasound can be helpful, but the information we have here is like, we don't know much. I don't think I heard something about the time course, but we have an 18-year-old male, which is interesting because he's quite young. And then my first reflex thought was, there's this Meulengracht. I'm not sure how to say this, whether it has different names, but there's this benign cause of jaundice that is like genetic and is often associated with this like young male. So we can think of that. And then otherwise, I would want to know more about this patient to kind of know and put this into more perspective. Yeah.
Yeah, I think you're spot on. I think you need way more knowledge, but what you've given us so far is a great lay of the land of jaundice, which jaundice often means that there's an issue with the hematological system or the other H, the hepatic system. And so whenever you hear jaundice, think heme or hepatic, just keep it simple. And there's a lot more data necessary to be able to make progress. But an interesting reflection for us to go through now is to say, just based on the fact that this patient is presenting with jaundice, presumably alone, meaning that he isn't so far saying anything else, does that give you a little bit of guidance into which bucket you might be in, heme or hepatic?
I would be more into hepatic because
Yeah.
with I think we would definitely have more systemic symptoms and other issues.
I completely agree with you. It's amazing to pay attention to what we talk about on the clinical problem solvers as a center of gravity. The center of gravity in clinical reasoning is basically the sense of like, what is the relative weight of all the things added together? And I think that here, when jaundice is the disproportional manifestation of the disease process, it's very unusual for it to be a hematological issue. Jaundice, it tends to be at a extreme point in patients with hemolytic anemia. So with just this information alone, I think hepatic is all capital and heme isn't gone. It's just much smaller font. And we'll see how Amanda gives us some guidance about these possibilities.
So the patient relates jaundice accompanied by a non-thermometrated fever, vomiting, fecal acholia, and coluria, followed by abdominal pain in the right hypochondrial 1 month ago. In the past medical history, non-allergies, non-blood transfusion, alcohol, and is a non-smoker, and don't drink none and medication.
So if I'll try to summarize and then you can see
thank you.
something. But so this patient had an episode of vomiting and diarrhea 1 month ago and is now presenting, and I believe he doesn't have it anymore, but is now presenting with jaundice. Is that right? And then no other, no allergies, nothing in the past medical history or anything. So basically we have this episode of kind of gastroenteritis, whatever it might be, and now jaundice. I think with what happened 1 month ago, in such a young patient, my first thought would be something infectious. And then now I'm trying to kind of link that to jaundice, or whether there might be something. I don't know. So I think I'm kind of stuck here at the moment.
Yeah, no, I think that you reached the limits of what we can reason. I think our summary here so far, like initially, just to be systematic, jaundice, heme or hepatic. We got abdominal pain in the right upper quadrant, along with acholic stools, the stools that are less colored. All of them are features of liver disease. So I think, yeah, now we're definitely sure it's the hepatic category, and I think we can almost eliminate heme. The reason not to eliminate heme definitively is patients can have both heme and hepatic diseases, with the most common global example being a patient has a chronic hemolytic anemia, gets gallstones, and those gallstones can cause hepatic consequences. And there are many other overlaps, including Wilson's disease, which causes both heme and hepatic issues. But I think the case for hepatic is very strong, and you picked up on one very important point, which is this patient has an inflammatory hepatic disorder with the fever present. And so now the question is, without any more data, how do you think about infections in the liver? How do you break that space down?
Well, with infections, I would start with the most obvious one, like hepatitis, like viral infections. Then also there could be any other infection that might be bacteremic and then spread to the liver and manifest there. We could have other viral infections such as EBV, CMV, who have kind of this tropism to the liver, HIV. And then I think also these tick-borne infections that can also affect the liver, which I wouldn't associate with diarrhea, so like primarily. So I think other viral causes would be more more probable. And then I think we have other bacteria, like more atypical bacteria like chlamydia, that might also be associated with hepatitis. And so I guess my the first thing I would think of, especially with the diarrhea, is like viral causes.
Absolutely amazing. I think that's a really great differential diagnosis, and it reminded me of a case that you presented of the disseminated Neisseria meningitis in the belly that was almost like Fitzhugh-Curtis, which is definitely a way that you can get infections and diarrhea. What's your overall feeling of this case? Are you worried about how tricky it is, or where is your mental space at in terms of just the challenge that that this case is giving you?
I think a very good challenge is not having the information written out and just
Right.
it like this. So, but then I think what I'm wondering here at the moment is, what is his complaint now? Is it just the jaundice?
Right.
And why did he, is it just that he's worried about the jaundice and now he's presenting, or is there something else going on?
Part of me is so glad that we don't have the whiteboard, because it's replicating real life. In real life, the information that you're working with is often of questionable value. You don't really know who said what. Like when there are many people or patients or consultants involved, it actually is reflective a lot of what real life is. And being able to filter what is important and what is not is very tough. And I think you're doing it really well so far. My grasp of this case is that this is an inflammatory liver disease, presumably infectious, and we'll have to open up the DDX to something else. You've given us a really good list of infections that affect the hepatic parenchyma, viral infections and others. Can you think of a very important life-threatening infections of the extrahepatic biliary tree?
I'm not sure I understood the question.
Can you think of any infections that are in the bile duct that can also cause jaundice?
Well, we could have maybe parasitic infection.
100%.
But I'm not sure I'm thinking about the one you're thinking about.
No, 100% right. Like, and the truth is, Leah, if you tell me somebody has fever and jaundice, I now have to convince myself that this patient doesn't have cholangitis. That's the most important life-threatening diagnosis. I would venture to guess the reason that that is not imprinted on your mind right now is because the time course of this disease process, a month, is less compatible with cholangitis. But if I told you, Haley, I have a patient right here who has fever, jaundice for one day, you would probably be most worried about cholangitis. So the question is, how does the fact that this has been going on for a month alter that consideration? And I would say it shouldn't, because cholangitis is so morbid that we have to entertain that possibility. So what's the bigger picture learning here? To keep the case simple, Leah, jaundice, hepatic now. Hepatic plus infections, I think there's a tendency to jump to the intrahepatic space as the location of those infections. Why? They're the most common. Hepatitis A, B, C, D, EBV, leptospirosis, all those are way more common. But the extrahepatic infections, namely cholangitis, are more morbid. So even though we often end up in the liver itself as this location of the infection, the initial glance is probably better towards the extrahepatic biliary tree, driven by morbidity alone. So I think that's the calculus that we have to have, is where is this inflammation? Is it in the liver or is it in the common bile duct? And as you said, only imaging will definitively answer that question. The lab test will be a helpful place to start. All right, Amanda, give us more, please.
So in the vital signs, we have a temp 37.5, a heart rate, it's 90, the blood pressure is 110/60, the SATs is 98% on room air, well, jaundice in 2 cruces and 4, no flapping, pulmonary and cardiac systems without chains, and mild pain on abdominal palpation without other chains, Murph and Bloom-Black negative.
Amazing.
Investigate.
Go ahead, Leah. I think we can think about the exam in a minute or two, just to make sure that we can do this in 30 minutes, then move on to lab. So what are your reflex thoughts with this exam?
my reflex thoughts is not too worried with the vitals and also with the abdominal exam, and no specific signs for cholangitis or cholecystitis or anything specific. There was not even right upper quadrant pain, is that right?
Not really. Yeah, and the Murphy sign was also negative. So Amanda's putting the information in the chat so we can reanalyze it one more time. But Leah, I think one good thing for you is to kind of mentally clear yourself and say, it's hard not to think about this case with the pre-data that you already have, but remove yourself from it for a second and say, I have a patient who's jaundiced. In general, what do you think are the highest yield exam maneuvers in patients with jaundice? Like, what do you think actually helps you? Because I will tell you, most of the time in a patient with jaundice, you're like, I need other data. But there's some data set that actually is tremendously informative. So what would you be inclined to want to know on exam for somebody who's jaundiced that you think will be helpful?
Okay, if I have to limit myself just on you, I think bile duct dilation on imaging, that can be very helpful to just distinguish broad categories still. And then also see like the liver enzymes, whether we have more cholestatic fat or hepatocellular, and that will also help us.
Beautiful, superb. Is there anything on physical exam that you think can help you a lot, or is that space kind of limited? What do you think?
For a patient where we already assume it's hepatic and not heme, I think just we can only make things more probable, but not that like make a definitive diagnosis.
Yeah, I think that you're spot on. I would say the exam for most patients with jaundice is not helpful at all, except one thing. And that thing can give you insight into what's happening in the liver with signs of cirrhosis. If you walk into a room in a patient with jaundice and you see distended belly, spider caput medusae, spider angiomas, asterixis, and you can make the probability that this patient has cirrhosis. Jaundice in a patient with cirrhosis is very different than jaundice without cirrhosis. What is the most important thing to do on physical exam in a patient with jaundice? It is to see if there are stigmata of chronic liver disease or not. And the fact that this patient does not have stigmata of chronic liver disease tells us that we're dealing with an inflammatory jaundice syndrome in a patient without cirrhosis. And that calculus changes tremendously, because if the patient had cirrhosis, we'd be doing so many things differently, including tapping the ascites fluid for spontaneous bacterial peritonitis. So the lack of cirrhosis stigmata is very, very helpful. And I think, as you said, the next steps are, what are the liver enzymes and what is the imaging? Those are going to be very, very informative. All right, Amanda, tell us more.
So now breathe, don't freak, because we have a lot of labs. First, hemoglobin is 15, WBC is 6,000, platelets is 200,000, iron is 251, ferritin is 811, sodium is 140, AST is 474, ALT is 323, creatinine is 0.8, BUN is 21, total proteins is 8.6, albumin is 3.8, alkaline phosphatates is 131, GGT is 187, and we have total bilirubin 4.2, direct bilirubin is 2.9, alpha fetoprotein 30.9, and gamma globulin 2.7. I will send in the chat.
Thank you, Amanda, for those labs. So I'll start with the beginning. I think we had normal, like hemoglobin was normal. So basic white blood cells too, and platelets as well, which again, just I think especially the platelets confirm that cirrhosis is not at play. And then I think with the rest, the first thing that's still stuck in my mind is the elevated ferritin and iron. And of course, with liver, we think of hemochromatosis as the reflex thought at first. But then I also want to not anchor on this and think, might there be other reasons why this patient is like iron overloaded? And I don't know, just maybe in this case with this past medical history is not the case, but like transfusions can be a cause where that might be the case. Continuing with the pattern, it's more, we definitely have elevated hepatocellular LFTs or liver enzymes. So we have more the hepatocellular pattern. And there were, I think, alpha-fetoprotein, where I don't know how to interpret that because I haven't looked at that yet in the context of much, to be honest. And then what else? Yeah, I guess hemochromatosis is an inherited disease, so might be with a young person, but then again, how does diarrhea fit into this? So that's why I'm still also not sure it's a good idea to anchor on that. Yeah, Robbie, what do you think?
Absolutely marvelous. I'm just going to summarize. We had an 18-year-old man with jaundice. We were figuring out, is it heme or hepatic? Then we got abdominal pain and acholia, so we said hepatic. And then we said hepatic on exam with cirrhosis or without cirrhosis. Now we're like hepatic disease without cirrhosis. And so what do the labs do? The labs clarify that it is hepatocellular in nature and not primarily cholestatic. The AST, ALT are much higher than the ALK phoses. So this is probably an intrahepatic issue as opposed to extrahepatic issue. So we can reframe this problem as acute liver injury, right? There's no signs of acute liver failure because there's no coagulopathy or encephalopathy. So the question is, let's just focus and generate our differential diagnosis for acute liver injury, and then we can use the other pieces of data like the diarrhea or anything else to prioritize. So Leah, when you hear, you go into a separate room, not this case. When you just hear the words, oh, acute liver injury, what categories of processes do you start to think about?
I think it's something I also, I think I heard on VMR that the difference or more vascular causes are more likely to be the cause for injury versus like toxins and viruses. I would associate more with failure. So I guess that would be kind of where I would orient my differential.
That's absolutely superb. So in acute liver injury, the plumbing is much more likely to be caused, either biliary plumbing or vascular plumbing. In the biliary plumbing, we talked about there's no cholestatic issue, so that's not at play. Vascular causes are essentially ischemic hepatitis, and that almost always occurs in the context of heart failure. So in the lack of heart failure symptoms here, I think we are in that actual liver problem itself. And so you said it, the most common causes are infections and toxins. And while we don't have any medications here, we have to query the possibility of liver occult toxins as herbal medications, for example. And no matter what, this patient needs hepatitis serologies. And you already mentioned hepatitis A as a possibility in this case early on. There's one other important consideration to have that you wouldn't have otherwise, but skewed and inferred by one key piece of data here. And that key piece of data is the protein gap. So again, let's move into another room, Leah. What do you, when you hear about protein gap, what does that mean to you?
Well, the protein gap
to me
is that the plasma protein
Yes.
is made up of more than just albumin. So
Excellent.
there's protein that shouldn't be there because the majority of the protein is usually made up by albumin. So I think now we have to think about what other causes could be proteins with this patient.
Exactly
And
right.
then, yeah, I think it would be interesting maybe to do kind of an SPEP and see if there are any spikes, or just see what kind of proteins might be elevated.
Absolutely superb. The next step is to do an SPEP to make sure, is this a monoclonal protein or a polyclonal protein? If you study the overlap of polyclonal, if you study the gap of protein gap plus acute liver injury, there are two prominent causes. The most common is hepatitis C. Hepatitis C causes a very common protein gap, issues with protein gap. The other one is an autoimmune hepatitis. Hepatitis C we should test for in this patient for sure, given the fact that it's on the hepatitis differential diagnosis. And now, because of the protein gap, we should also test this patient with autoimmune hepatitis. We actually already have one test available to us that Amanda snuck in, and that's the IgG level, so the gamma globulin. The fact that the gamma IgG is also very high is very concerning for autoimmune hepatitis. So what are the most common causes of acute liver injury? Infections, toxins. Infections, we have to test for all of them, but this patient is giving us a flavor of autoimmune hepatitis. So I think it would be very helpful to get an ANA and an anti-smooth muscle antibody. Those would be very, very informative. So Leah, I think to summarize, the world that we're in is acute liver injury, plumbing, infections, toxins. Protein gap, monoclonal or polyclonal. Most of the time it's polyclonal. And the most common causes of a polyclonal protein gap overlapping with acute liver injury are hepatitis C and autoimmune hepatitis. So we still have to work up the acute liver injury, agnostic to the protein gap, but the protein gap causes get a little bit of highlighting as things we'd emphasize. Any questions about any of that?
I think no. Now I'm curious to see what the results are.
Yeah, me too. Amanda, let us know.
So it's so exciting. We have more examples. HBS, AG, it's negative, anti-HBC, anti-HBS, anti-HCV, and anti-HAV, EGM, and EGG, all negatives. HIV, CMV, and toxo, negative. ANA, antinuclear antibodies, is 101 per 160. So think in autoimmune hepatitis, hemochromatosis, and Wilson disease. We ask ultrasound. We have came to us heterogeneity of the liver parenchyma and decrease in homogeneous splenomegaly. I will send in the chat.
So Leah, I'll take the task of summarizing this time, which is to say that all the hepatitis serologies are negative. The ANA is very positive, and then an ultrasound shows splenomegaly. So what does that do for you?
Okay. Thank you for summarizing. I think we are. It's good to hear that the hepatitis panel was negative, and then with autoimmune hepatitis, I think there are different types and categories. So the most common subcategory would be ANA positive, which would fit in this case. And I know ANA is a very unspecific factor, so you have to always see if the clinical context kind of fits and to be able to interpret it. But I think in this case, because we have many things that would be compatible with autoimmune hepatitis, I'm not sure whether in this case you would then go on and further differentiate the IgGs to see to be more specific with the diagnosis, but it would definitely fit the type 1 autoimmune hepatitis. And yeah, I guess I'm now thinking about the splenomegaly. Splenomegaly, that's why I'm kind of looking away. But I think with the splenomegaly, it's also a very unspecific finding, but it's an autoimmune disease. And we always often have a splenomegaly associated with that as well. And yeah, I don't know. What do you think, Rob?
Yeah, I think the fact that you're discussing such a complicated case and doing it with both confidently saying what you do know with such clarity, but what I admire the most isn't that, it's just how clear you are about the things that are gray in your knowledge base. You know a little bit about them, but not enough to look straight at the camera. You have to look away. And that's amazing. I really, really commend you for that. I don't have anything to add about your analysis to autoimmune hepatitis, apart from just to say that the clinical criteria to make a diagnosis in real life are three things. You need to have negative hepatitis serologies. You need to have a positive ANA. Ideally, you would have a positive anti-smooth muscle antibody, but that's only positive in about half patients. And then you would do a liver biopsy that confirms the diagnosis with some characteristic plasma cell-based findings. That's the fundamental arm. How can you be very confident this patient has it? It's actually the splenomegaly. And let me tell you how. While this patient doesn't have overt cirrhosis, these signs are clearly signs concerning for portal hypertension. So the fact that their spleen is big with liver and nodularity changes is evocative of early cirrhosis. So now we have a different problem representation. We have acute on chronic liver injury. And there are only 3 diseases that can cause acute on chronic liver injury: hepatitis B, Wilson's disease, and autoimmune hepatitis. Let me be clear. I'm talking about acute on chronic with acute to this severity. You may say, wait, alcohol can get acute and chronic, but alcoholic related liver disease rarely results in liver enzymes above 400 or 500. So acute, meaning acute and significant on chronic, hepatitis B, Wilson's, autoimmune hepatitis. While we have not ruled out Wilson's disease in this patient, the positive ANA, the lack of neurological features, the lack of hematological features are very evocative of autoimmune hepatitis. So I think that it's based on your resources whether you start treating the patient now or you do a biopsy. But the splenomegaly reinforces the notion of acute on chronic, and the acute on chronic is almost always just one of those 3 things. All right, Amanda, tell us more, please.
So with the results and with the focus to hypergamma globulinemia and the ANE, we started an empirical treatment for autoimmune hepatitis with prednisone, 40 milligrams per day, and azathioprine, 100 milligrams per day, and the patient evolved with improvement, closing the diagnosis of autoimmune hepatitis.
Oh my gosh, Amanda, what an incredible case. Incredible. I'll love to hear what you learned in a moment, but I'm curious, Leah, what do you think of this diagnosis and how did it feel to discuss?
Well, first, thank you so much, Amanda, for bringing this case. I think it was a great one to discuss and to think through. And yeah, discussing it was challenging, especially because I'm a very visual person, and when you only hear it, it's kind of, you have to really make sure you hear and keep the information, but it's really good practice. And I think there were a lot of, like, I love even at the end how the splenomegaly then changed how we thought about the disease time course and what kind of information we got just out of this one clinical finding. But yeah, still lots of reflections to make, but it was a lot of fun and also nice to have you guide me through this, because I think, and that helped a lot in the process.
It was a real pleasure. I admire you for your bravery to discuss in front of so many people and to be so authentic about what you know and what you don't. And your commitment to push yourself to learn and grow is very admirable. I think all of us enjoy bearing witness to that. Amanda, how did you take care of this patient? How were you involved in this patient, and what did you learn?
So, Robbie, it was a great case, and I learned so much from his, because HIE, it's a difficult diagnosis. I don't know if it's because it's a diagnosis of exclusion. So we do all the screening to liver disease, and we have to request all the testings. And after the results, negative results, we have the final diagnosis. So in this case, I give the importance to differential diagnosis, and increased me too much.
Really, I can't tell you how hard it is to make this diagnosis. I think that you set us up by giving us all the data at the right time. And I can tell you know this well by how you chose to get this information. But it is a very, very hard diagnosis to make. And in many parts, it's so hard that you need a biopsy. But in your case, I agree. I think the case was so strong that I'm glad you gave the patient treatment and that they got better. Absolutely amazing job. Yeah, it's always a treat when we have Amanda presenting. It always brings such wonderful cases to us. We really, really appreciate you, Amanda, and look forward to the next case you present. All right, y'all. I'll summarize one or two teaching points that I took away from this case, and then ask Leah to just say her favorite. I think the biggest learning point for me in this case was just this case prompted me to realize how important the physical exam is in patients with jaundice to determine if they have cirrhosis or not, but how limited that can be. Because I erroneously said, oh, the patient doesn't have cirrhosis. But it turns out that they probably had some clinical cirrhosis, and that was really important to filter the differential diagnosis. So look for cirrhosis on exam. It can profoundly change the calculus, but just because you don't see it on exam does not mean it's not there. And that was a great reminder by Amanda's ultrasound. Leah, what was your favorite learning point?
I think my favorite learning point also connects to that, and it's just to see how clinical exam findings can have an influence on the time course or the information you have on the time course of the patient. And in this case, this, just as you mentioned, these signs of starting cirrhosis with the splenomegaly, how that even was another way to narrow down the differential. I think that was my favorite point.
Amazing. Thanks, everyone. We'll hope to see you around on VMR. Thanks for hanging out. Thank you, Leah. Thank you, Amanda. And thanks to everyone who was here. Bye.